So Ray, David, and I have been on the stage together quite a bit, along with Thornton Kirby, who runs the Hospital Association. It's actually, when we do that, you would think we all work for the same organization, because I think about 90% of the conversation, we're in agreement about where we are with healthcare right now and where we need to be moving. And then we get to this 5%, which is this Affordable Care Act thing, and we start to disagree. But I'm going to talk today about, obviously I run the Medicaid agency, which is the government program Medicaid for individuals living with disabilities or who are poor in the United States. Medicare is the program for the elderly. We serve about 1 million people in South Carolina annually. Actually this year it'll be about 1.1 million people will receive insurance through Medicaid. And that's always growing. And so I'm going to talk about that. And so my presentation is mainly going to be about healthcare in general and the underlying problems that we're experiencing, how that affects the Medicaid program, which y'all are paying for. And then we can talk more during the question and answer period about exchanges, about some of the concerns that the hospitals have and so on, and about the private market, which I spent a lot of time talking to folks about, but I don't have direct responsibility to manage like the Department of Insurance may have. So I think it's important. Peter Drucker said one of the biggest dangers is not getting the wrong answer, but asking the wrong question. And I think when we start talking about healthcare, many times we don't really know what the question is and what we're trying to solve. And part of our problem with the Affordable Care Act is that we think it really asks the wrong set of questions to start. It asks, how do you insure as many people in the United States, when we really think the question should have been, how do you get as many people healthy in the United States? And there's a big difference between health and health services and health insurance. And the Affordable Care Act gets that it all mixed up. And by starting out asking, how do you insure as many people as possible, you get the Affordable Care Act, which is mainly an expansion of insurance on the private side through the mandates, and on the Medicaid side through the Medicaid programs in the 50 states. And that's really 95% of the entire law, and then 5% in the middle has to do with public health and sort of nibbling around the edges on the insurance side. But we are trying to bring it back to health, and the triple aim, which is a set of objectives that pretty much all healthcare leaders have bought into now. Don Berwick, who was the head of CMS for a couple of years for President Obama, was the prior president of the Institute for Healthcare Improvement, which was a voluntary effort by hospitals and other health organizations to improve the healthcare system. And he came up with a triple aim, and it's really taken hold. And so I'm going to talk about the Affordable Care Act and what we're trying to do with the healthcare system from the perspective of the triple aim. And the triple aim has obviously three major components. The first is to reduce the per capita cost of healthcare in the United States. And as I'll talk about, it's clear that we are spending way too much money in the United States on healthcare for the value, for the services and quality that we're getting. Two, improve the health of populations. And so really thinking about population health as a goal, because the United States is falling further and further behind other developed countries on major indices of population health, such as life expectancy. And then third, improve the patient experience in the healthcare organization, quality, service. I'm not going to talk as much about that one. I'm going to talk about the first two, but I can, during question and answer, talk about the third. So to talk about spending growth, I just want to make sure we're all on the same page. As you can see here, there's almost exponential spending growth in healthcare in the United States. I'm using exponential a little bit loosely. What actually happened is, for the first few decades after the introduction of Medicare, healthcare spending actually tripled every decade for a few decades. It started to slow down now, but it's about doubling every decade. The Affordable Care Act has slowed that down a little bit, but by no means has it reversed the increase in healthcare spending growth, which is really where we need to start to go. And you can see in 2009, 10, and 11, we actually had our lowest growth in the healthcare sector on record. And a lot of folks think, well, see, we're finally getting it right. The problem is that real GDP during that same 3 years actually contracted in 2009 while the healthcare industry was expanding, and it's continually grown faster than the economy. Comparing that to other countries, I think is important, especially as I listen to the folks who are in this room, because these are all the countries that we're competing against. And in terms of, are we spending too much money on healthcare in premiums that we pay in our organizations or in the taxes that we pay to support healthcare, it's pretty clear that we're spending a lot more than any other country from just a total dollar amount, but we're also spending more, much more than any other country in terms of the percentage of GDP. And you all have probably heard this many times. This slide actually, I think, is the best representation of it, because it's long been known that health spending across countries is very highly correlated just with the per capita GDP of the country. And so you see a very, very tight correlation that as income goes up, so does healthcare spending. And what you also see is this red dot up here, that's the United States. So way off the charts in terms of healthcare spending. And then there's, I think, little Luxembourg is over here, so they're a really kind of rich country in Europe. They don't even spend as much money as we do, even though their per capita income is much higher. So the U.S. is a major outlier here. All right, we're spending way too much money. And the problem is, it's not getting any better. If the goal of the triple aim is to reduce per capita healthcare spending, the Affordable Care Act is not doing this, because the projections by CMS in 2020 is that we spend even more of our dollar, more of our paychecks, more of our payroll on healthcare than we do today. So the Affordable Care Act is not reversing this growth, it's actually contributing to it. And so when we think in the bigger picture, some of the concerns that the hospitals have about money being taken out of the system, money is not being taken out of the system. Okay, I want to be clear on that. Money is not being taken out of the system. There's lots of talk about the federal deficit being lowered because of the Affordable Care Act, but lowering the federal deficit doesn't mean taking money out of the system. It means taking more money from all of us, because there's hundreds of billions of dollars of new taxes to pay for it to help reduce that deficit. But more money in the system overall is the result of the Affordable Care Act. Okay? Now, the problem with that is that the Institute of Medicine, the problem with that from a purchaser perspective, and we're all purchasers, and I don't say we're all payers, because ultimately the payer is the individual, no matter what. The money always comes from the individual, but we're all purchasers. The problem I have is that with this is that 1/3 of all healthcare spending is waste, according to the Institute of Medicine. You know, the Institute of Medicine is all the big brains up there thinking about healthcare from a non-biased perspective, presumably, and they've taken a look at the research, and in the past year and a half have written 3 separate reports that all talk about this 1/3 of healthcare spending as excess cost. And so we're doubling down on a system, we're expanding by 30 million people, a system where 1/3 of all healthcare spending is excess cost. Now, it's sometimes hard to put that in perspective, but in their last report, they said, well, let's put that excess cost in perspective. 1/3 of the healthcare expenditures in 2009 was about $750 billion of excess costs that doesn't contribute to health. What can you buy with that? That, to put it in perspective, is $100 billion more than the annual defense budget in the United States, just the waste in the healthcare system. It's enough money, just the waste, to pay for 150 million people their health insurance premiums. That's bigger than the entire civilian labor force in the United States, just the waste. And it's 1.5 times the total 2004, and I guess 2004, because that's the latest data they had, national infrastructure investment in roads, railroads, aviation, drinking water, and so on. So The Institute of Medicine has been warning us for the past few years that this massive growth of healthcare spending has been crowding out investments in other important areas that states need to make, such as education and infrastructure. It's also depressing economic growth in the United States. It's depressing wages because every dollar more that you have to pay in healthcare comes out of an employee's pocket. You're not hiring as much, you're not making capital investments because of this growth. For time's sake, I'm just going to quickly go over these, but you can see those two lines on the bottom. This is the growth in the federal budget of Medicaid. This is the growth in the federal budget of Medicare after premiums are taken out. And so you can see about 23% of the federal budget is now being spent on Medicare and Medicaid. This next slide shows that 50.9% of federal revenues are being spent on those two programs. And what's the difference between 23% and 50%? If 23% of your budget is healthcare and 50.9% is revenues, what's the difference? It's borrowing. We're borrowing all that money. All that money is being borrowed, and this is the system that we're growing. So the triple aim about reducing per capita costs under the Affordable Care Act is not really addressing that. I think we've established. The second thing is improving population health. So during the time that all this money has been spent, and there's that growth in healthcare expenses, what's happened in the United States? Well, in 1950, life expectancy was 68.9 years, and we were ranked 12th. Life expectancy has gone up as it has around the world, and now in the U.S. it's at 79.2 years. But we've gone from 12th to 28th. We're falling further and further behind in the United States. South Carolina is ranked 42nd, and so if we're 28th in the world, and then South Carolina is 42nd, you can imagine how we are compared to a lot of other countries. What's even more disturbing is that life expectancy has actually fallen for certain groups in the United States, which rarely happens around the world unless there's some sort of epidemic or genocide or something like that. I mean, something serious happened. And you can see for women who have, this is a slide of life expectancy for white women according to their years of education. You can see that life expectancy since 1980 has actually dropped for white women with less than a high school education by 5 years. I mean, this is a profound change in the life expectancy of women in that education group. And there's lots of opinions as to why that we can talk about later, but this should not be happening, especially for all the spending that we're doing in the U.S. So another view of population health, for all the spending that we're getting, are we getting improved population health? This is taken from the Hospital Association, and actually Thornton has a very nice progression of 20 or 30 slides that shows how these maps change over time. But you can see in 1990, taking a look at obesity in the United States, that the scale only went up to 15%. They didn't even have this part of the scale over here. And so there wasn't a state in the country that had more than 15% of its population obese. Now we're in 2000, you can see they had to add another set onto the scale to get up to 24%. And now we've got, in 2010, the scale's got to go to a plus 30%. Because the country just got increasingly obese, and when it's getting increasingly obese, it's getting increasingly less healthy. So all that spending does not improve the population's health from this perspective. And then finally, if you take a look at this is a map of South Carolina. This is essentially a map where we take a bucket of diseases, and we take every Medicaid recipient, every adult Medicaid recipient, we say, all right, you have this disease. And then we put a little dot, this is hundreds or tens of thousands of little dots throughout here. And so every adult Medicaid recipient is recorded on here. And if you're in a white area, that means you're at the average level of, or average prevalence of this bucket of diseases. And if you're in the red area, you are 2.5 standard deviations or more below the average. And if you're in this dark blue, you're 2.5 standard deviations, or actually below the average, meaning you're healthier. So blue is healthy, much healthier. Red is much less healthy. This is what we all know. I mean, everybody knows that this is the quarter of shame right here that we talk about. or the belt buckle of the stroke belt. This is no surprise to anybody. But what should be a surprise is all these people have health insurance. Everybody on this map has Medicaid. And so everyone up here who's super healthy has Medicaid. Everyone here who's super unhealthy has Medicaid. And so you have to ask yourself, well, what's happening? Insurance does not seem to be necessarily a primary determinant of health. And yet insurance is where we keep pouring more and more money into. And if you actually look at some of the differences in these counties and try to ask yourself, well, what's the big difference? Some of the big differences I see is that the graduation from college is much higher in the blue area than the red area. Not from high school, they're about the same, but these folks are graduating from college at a much higher rate. The number of families headed by a single parent is almost double in this area, 50-60%, compared to this area, which is around 25 to 30%. So you start to see these more complex social determinants that don't necessarily have anything to do with health services. So is the Affordable Care Act addressing these problems? No, it's not. The Affordable Care Act is an insurance plan. It's just a way to put more money into insurance, and because insurance follows the person and doesn't follow the problem, where's most of the money going for the Affordable Care Act? It's going here, here, and here. Well, this is where the problem is, right? So all of you know in your businesses that you put your money where your problem is. The Affordable Care Act is putting its money where all the people are, which are already much, much healthier than the rest of the state. So from a state trying to spend limited dollars to solve very significant problems, Affordable Care Act just perpetuates this problem, all right? So let's talk a little bit about what the Affordable Care Act really does. Let's talk specifically about the Medicaid expansion. So the expansion in the Affordable Care Act is divided into two main areas: the private expansion through the health insurance exchanges. And we've said, we were one of the initial states to say, we've looked at it, we think it would be better that the federal government run the exchanges and not the state. Now probably about 30 states are doing the same thing, and going to let the federal government run it. That's all going forward. The Supreme Court said the mandate is permissible as a tax, and so that's going to happen. What it said was unconstitutional was forcing the states to expand Medicaid, that the president had exceeded his authority to promise that. And so now each state is taking a look at it separately, which I think is great, because I think for some states it might be smart to expand Medicaid, but it is a state-by-state decision, and now we're having really good conversations that never happened before. But essentially what happens in the Medicaid expansion is that a whole new category of folks in this red area get access to Medicaid. Medicaid is a mixture of, do you have a specific need in a category, and so you're categorically, for instance, pregnant women, you become pregnant, that's one way to become eligible, and if your income is below 185% of the federal poverty line, those two things together, you become eligible for Medicaid. What the Affordable Care Act does is it essentially wipes out those categories of eligibility and just says it's now all based on income. So anybody below, it sets a new floor, and it says anybody below 138% of the federal poverty line, regardless of your need, gets access to health insurance through the Medicaid program. And so what that means is about, if we did full expansion, that about 513,000 new people would come onto Medicaid. About a third of that is actually people who are already eligible. So there's a lot of people out there who are already eligible but don't choose to enroll in Medicaid. One reason is because about 100,000 of them have private health insurance. Okay? So they're actually making the conscious decision to contribute to their own insurance, most likely through their employer. The other 2/3 of that are people who are newly eligible, about 350,000 people. But one of the big problems, again, we have is that if you expand it, 200,000 people are projected to drop private insurance. That's not smart from a policy perspective, because people have already said, look, I want to pay for this. I think it's important. I prioritize my dollars. I'm working with my employer to bring money into the system to pay for my own care. And now the government is saying, well, okay, that's important to you, but we're going to replace it with all federal and state money. And so That's not a desirable policy outcome. The other problem should really be from the hospital's perspective, is that you go from a better payer, which is private insurance, to a worse payer, which is Medicaid, when you do this big expansion. And that's going to happen without Medicaid expansion anyway, and is part of the conversation with the hospitals about what's going to happen to their bottom line. But the important thing here to note is that if we expanded, we'd have 500,000 new people. It would be a 50% expansion of Medicaid in South Carolina. About 1 in 3, a little bit over 1 in 3 of everyone in the state would now be on Medicaid. This is a big, complicated slide about the cost, but really the top is all we need to focus on. And I think it's important to recognize that this conversation shouldn't just be about expansion, because all those numbers about that crazy growth that I saw, or that I showed you before, and about the declining health in the United States, that's in the current system. That's the current system's performing so poorly. And so the current Medicaid program between now and 2020 is going to need $2.4 billion more of state tax dollars than it does today, cumulatively, okay? So the current program is still chugging along, and it's going to need $2.4 billion more in state tax dollars. This year alone, I originally submitted a $194 million request of additional state tax money, which was more money than the state had available next year for everything, new dollars. Now, we pulled that back after going through it to about $156 million. The BEA just recognized some more state revenue, but we're still going to take well over half of all the new revenue that the state has to spend next year. So all that money that we take is less money for roads, which have got apparently a $29 billion backlog in infrastructure, is less money for higher education, which has been cut year after year after year, and that's why tuitions are rising. So, so this is money that's coming from someplace else. If it doesn't come from someplace else, then we have to spend it. Where's it going to come from? It's going to come from y'all. It's going to come from taxes. And you can look at states around the country. They are raising taxes in anticipation of the growth of the program and the growth due to the Affordable Care Act. Now, expanding then will cost an additional $613 million to $1.9 billion of state tax dollars. There's such a wide range there because we have two big projection risks. One is how many people are actually going to sign up, and a lot of that depends on what's going to happen in the private market. And two, how much we're going to have to pay for those services. Because there's no more doctors that are coming into the system, right? And so when the demand, because you bring all these people into the insurance system for services goes up, and supply stays the same, what happens? The prices, they go up, right? None of the Affordable Care Act projections projected any of that. They said, well, that's too complicated to figure out. Well, yeah, it is complicated, and all of us in our businesses have to worry about prices, right? That includes Medicaid. And so that range is so big because we have a lot of projection risk related to this program. And so anybody who says, well, this is exactly what's going to happen, we know this is going to happen, here's the number, don't trust them, because there is no way that we can be more confident in this very large range right here, 600 million to 1.9 billion. I think the other important thing to understand is that this whole debate had a terrible lack of nuance. It started out with death panels, which were an extremely unnuanced view of what people were trying to do in terms of getting healthcare costs under control. And now it's flipped over to the other side of that, oh, if you don't expand Medicaid, nothing's going to happen. Everything's just going to get worse. Nobody's going to have insurance and so on. This is not the case, because two things are happening that I referenced before is that the health insurance exchanges are still going forward, right? So all those federal tax subsidies to buy insurance and the penalties and so on, that's all happening. And also there's this growth in the Medicaid program that we can't do anything about, even if we said no to expansion. It's just going to happen anyways. And so the projections is that we're going to go from 17% uninsured, 731,000 people at any one time, down to 210,000, which is 5% uninsured over the course of the next 2 or 3 years, without Medicaid expansion. Now, I actually am trying to be a little bit more nuanced about the uninsured